Welcome to Moving Medicine, a podcast by the American Medical Association. Today's episode is part 2 in a discussion about patients and pain care. Chair of the AMA Board of Trustees, Dr. Michael Sook, talks with leaders from the Federation of State Medical Boards about its revised recommendations for opioids and pain care, as well as how medical boards are addressing access to treatment for patients with pain. If you missed part 1 of this series, you want to go back and give it a listen. Here's Dr. Sook.
Thank you for joining us this afternoon. I'm Dr. Michael Sook, Chair of the American Medical Association. Joining me today are Humayun Chaudhry, DO, President and CEO of the Federation of State Medical Boards, Sarvam TerKonda, MD, past Chair, Federation of State Medical Boards, Sherif Zaafran, MD, Board Member, Federation of State Medical Boards. Looking at it from a patient perspective, what advice would you have to a patient when they can't access or afford non-opioid options that are recommended or are denied opioid therapy, even though it's recommended?
Well, as you alluded to earlier, the No Pain Act looks like it's giving a directive to payers to actually pay for non-opioid modalities. So I certainly hope that will create a shift in not only incentivizing, but mandating that payers actually pay for appropriate therapies. I will never forget the frustration I felt. I'm an anesthesiologist, and I work with surgeons to make sure that we have an appropriate way of making sure that patients, after they go home, are managed well. And when a patient comes back and tells me, you prescribe this multi-modality or this multi number of medications that are out there, you prescribe the non-steroidal anti-inflammatory, you prescribe this opioid, and you prescribed, these other medications. The opioid cost me $2 as a copay. This non-steroidal anti-inflammatory cost me $200. Well, you know what? I'm just going to have to give up on that non-steroidal anti-inflammatory and just use this opioid that's over here. Or when you have opioids that are basically essentially combined drugs or combination drugs. So, obviously a lot of these medications are acetaminophen combined with either codeine or hydrocodone or oxycodone. When they're in the hospital, we try to maximize the use of acetaminophen and minimize the use of the opioids. But the way medications are dispensed out in the community, it's not easy to do it that way. And what are physicians going to do and what are patients going to do? They're going to go to the least common denominator, which is what is easy. If you're managing 30, 40 patients a day and you have to figure out a way to prescribe medications that are probably best practice, but practically speaking, the way reimbursement works is actually incentivizing patients to do the wrong thing, then it doesn't matter what we say as far as putting guidelines out there. The practicality of the matter is that they're going to go where they can afford to go. So the No Pain Act, I hope that kind of pushes the conversation in a direction where you're actually managing patients with best practice, but it's also a conversation with patients, because what patients hear, and it was really important when we had our stakeholder meetings and we had chronic pain patients involved, what they hear is that we're going to limit their ability to access opioids. And in their mind, opioids are the only thing that at least have made them feel comfortable. So we've got to make sure that both physicians are having the right conversation with patients, that this is not about just taking away your opioids. It's about managing your process in a multidisciplinary way so that we can figure out for you what is the least amount of opioids that you can take while you are still becoming more and more functional, right? We've always heard this word about functionality being more important than, potential for perceived pain. But that perceived pain and functionality goes back to, again, the non-medical interventions for pain, which is the behavioral therapists. And a lot of those other modalities, like, again, things like music therapy and other types of therapy that can help patients. And how do we transition patients from chronic pain to acute plus chronic pain when they come for surgery and back into their chronic pain management? That seamless process going from primary care to surgical care and back to primary care. And from the surgical care standpoint, how do we make sure that we're managing these patients so that if they come in opioid naive, that a year later, all of a sudden they're still taking opioids? We know that about 10 to 12% of patients who are opioid naive who come and experience a surgical procedure, that a year later are still taking those opioids. What have we done as clinicians in helping not have patients go from being opioid naive to all of a sudden having to take opioids on a chronic basis what have we done to help minimize and mitigate against that?
Yeah. Thank you for that additional comment. It was referring to the No Pain Act. There was a specific question about whether acupuncture would be covered, and it's not specifically delineated in the act. However, the drive toward non-opioid alternatives, I think, may ultimately increase the window of opportunity for those who practice or want to prescribe acupuncture as one alternative. What are effective ways to address unconscious bias in the provider community that continues to impact chronic pain care, especially among marginalized communities, specifically thinking of patient populations like sickle cell disease, who were excluded from CDC opioid prescription guidelines until just recently? And I know all three of you dealt with this directly as you came up with the new recommendation. So I just open that up to maybe to elaborate a little bit more when it comes to inequity.
I've spoken a lot. I want to make sure that you guys get a chance.
Yeah, Hank, you want to take that one first?
Sure. I mean, it's a serious question. I think two things. One, our policy is focused on pain in general populations. It actually does not specifically address patients who have end-of-life care needs related to pain or sickle cell or other chronic conditions, where it's almost a feature of their everyday living. Those are exceptions. Those individuals definitely need thoughtful care, and hopefully they're getting that from the specialists that take care of them. For the general population, I think the other message of our policy is that we don't have enough pain management specialists, as we all know, around the country. You will come across patients with pain, whether it's acute, subacute, or chronic, and decisions need to be made thoughtfully. You need to be mindful of past histories that could, lead to a situation where you have opioid use disorder, either unrecognized or worsened by what's done to manage that pain. So really, part of our policy is recognizing that there is a complexity here, but we want to make sure everyone gets compassionate, thoughtful care. Be aware that there are disparities. Be aware that we have implicit biases, all of us, sometimes in the management of patients. But we have an obligation through our Hippocratic or osteopathic oath to take care of patients as best we can and be open-minded, but be on the lookout for signs that may suggest that there's an issue with prolonged use or a high dose use of specifically opioids. I think those are among the messages that we're trying to get across, but the disequity issue is a big one.
Medicine doesn't stand still, and at the AMA, neither do we. AMA members are physicians like you who are shaping the future of medicine. Become a member today and join the movement. Visit ama-assn.org/movingmedicine.
Dr. Suk, I think the other issue we really need to touch upon is that this is pain management. And I think one of the part of the comprehensive approach to this is to create an environment so that that patient can manage their pain, we're not guaranteeing that they'll have no pain, but live in an environment where they can feel comfortable with the amount of pain they have to function in society. And that's why I think it's really important educating the patients about the risk of opioids, no matter what disease process they may have underlying that's causing their pain. And again, part of that is a behavioral management, understanding that chronic pain will always be there, but we want to create an environment for yourself and provide the appropriate therapy so you can manage to perform your daily activities of life. And I think that's part of that, educating the patients about the risk of opioid use, making sure that they have to understand overdose protection, and they understand those strategies. We want to protect those patients and make sure they're getting the appropriate care.
Can I quickly mention one other thing, Dr. Suk?
Yeah.
The other thing we're doing is realizing that we have limited resources, though we care about this issue. One of the things the FSMB did, along with many other national organizations around the country, is to partner with the National Academy of Medicine, which I'm sure all of you know has an action collaborative looking at the opioid epidemic, at least for the past 5-6 years. One of the things, and that's in Admiral Levine, the Assistant Secretary of Health, is a part of that as a co-chair. One of the things we've learned is that there are some very good examples across the country in states and counties where there are some best practices emerging on how to manage, the issues that you raised, Dr. Sook. And so sharing those best practices, which could become a regional or a national model, is, I think, another way of looking at this. No one city, state, or region has the solution, or even at the federal level, but partnering together with clinicians who are actually dealing with this day in and day out is the way we get to understand this problem better and to do something about it.
Yeah, Michael, one of the things that the HHS task force did address specifically were these marginalized patients. Specifically, they did talk about sickle cell patients and other chronic patients, chronic pain patients that historically, experience chronic pain. And really a big part of it, earlier somebody talked about the education of medical students also, and making sure that there is awareness and that, implicit bias is something that is taught. A lot of times when these patients do come to the emergency room, the implicit bias is that these guys are opioid seeking. Well, they may be, but that's actually kind of a tertiary response. They are in pain and they are looking for comfort. And how we help manage that comfort really should be our first goal. It shouldn't be, the first thought that these guys are opioid seeking and they're just, trying to jump from one ER to another and so forth and so on. They might be, but that's actually a secondary, a tertiary type of reaction to something that is underlying that they are experiencing. And as Dr. TerKonda alluded to a little bit earlier on, a lot of that does include behavioral therapy and other types of modalities to make sure that their perception and their functionality of the pain that they're experiencing, which is real, is also something that has to be managed. You can't just take away the opioids for their pain management without addressing the other side of that first. It has to kind of go in conjunction. You can't just take one away and say, by the way, later on, whether you're able to access it or not, then we'll start helping you manage that part. Well, until they access it, they kind of need this other modality that's out there. And we've got to be very cognizant of that. What was said earlier on about not enough chronic pain physicians and access to care and so forth, again, we've got to be able to leverage the telemedicine that is out there, the federal rules that allow for better reimbursement with telemedicine. That kind of goes back to the days of COVID, and making sure that there are opportunities to help continue that, especially around teleprescribing with the appropriate guardrails. We at the Texas Medical Board refined our rules that were temporary during COVID around the prescribing of opioids. We still put a lot of guardrails around it with how often you need to see the patient physically, but allowing for some of those prescribing to happen in a telemedicine manner. So that, again, your rural patient doesn't have to travel 100 miles every 30 days or more frequently in order to access care that they truly may need. And again, going back to my initial theme, making sure that we keep these patients in a regulated environment and not inadvertently forcing them into an unregulated environment by the way we are forced to help manage their pain, whether it's a payment issue, whether it's an access to care issue, whatever they might be. We as regulators, yes, we need to regulate how the care is being delivered, but we've also got to work with policymakers and others to make sure that we take down those barriers that allow them to get proper access to care.
No, all very true and very, very insightful. You mentioned the medical students in our education process that we have going on. This represents, I think, a new frontier of kind of the things that we need to thoughtfully train students who are entering into the new workforce. These idea of team-based care, multiple levels, multiple inputs, and coordination, I think, is a little bit different than maybe, if I may say so freely, than when we trained, certainly. I wonder if you guys have any thoughts on kind of the future of pain management education, how these particular regulations can actually impact that, because I do think there's going to be a significant influence.
I'm happy to start, Michael. I spent 10 years in undergraduate and graduate medical education. I know for a fact that many MD and DO schools are doing their best to incorporate exactly what you said in their curricula for not just the first and second year students that are at the institution, but also prepare them for the third and fourth year clerkships that they do and ultimately residency. In fact, next month, we have the CEOs of both the AAMC and ACOM appearing before our board at the FSMB, so we can better understand what's being taught to the next generation of physicians. It is our belief that they are getting a better training, if you will, than any of us did in both team-based care, understanding the role of the physician, understanding that patients may not always tell you what they need, and it takes some time, which is not always available. I'm hoping AI may play a role in allowing us to spend a little more time with patients rather than the technologies that hopefully can ambiently listen and take care of the documentation, because patients need to be listened to. That takes time, and they need the care to be tailored to their specific needs. And that's not always possible with specialists. There just aren't enough specialists available. So every doctor has to be aware and understand and work with nurses, pharmacists, and others to provide the appropriate care.
Medicine doesn't stand still, and neither do we. AMA members don't just keep up with medicine, they shape its future. Help move medicine, join the movement. Visit ama-assn.org/movingmedicine.
Yeah, one of the things that I think we're missing also is, a fair amount of research going into helping manage this. There's a lot of genetic testing that can be done to allow us to help target our approach in pain management. There are certain medications that we know work better than others, opioids and non-opioids. I know we keep on talking about the payment issue, but if these things are not being paid for, then they're not going to be utilized, both in the psychiatric arena and in the substance use disorder arena. Helping leverage our technology and funding research, meaningful research, and how we understand how patients perceive pain and how we can manage pain, I think is going to be key in taking us to the next level and really properly managing it. And honestly, unless we destigmatize this whole thing, you're not going to get the kind of funding and research that I think is appropriate for what this warrants. Because unfortunately, things that are stigmatized don't necessarily get the kind of funding that it deserves. It may not be as sexy as cancer therapy and stuff like that, but again, remember, everything that's out there has a pain component to it. And unless we help manage that part in the whole process of comorbid conditions and other disease processes, we're never going to really be able to help, advance our understanding of how to manage this whole process. The only thing that we can do as regulators is work with what we have out there. As a physician, I can see where some of the problems lie and encourage, more research, more funding, more education, all these kind of things, more collaboration, taking down some of those barriers. But we've got to be able to destigmatize what we say in the arena, in the public realm arena of who these patients are. They can't be marginalized. And if you marginalize them, it's almost like they don't exist. And if they don't exist, then you don't have to worry about treating them. That really can't continue to be the case.
Yeah, thanks. Sarv?
Yeah, I think, in terms of the future of pain management, I think both Dr. Chaudhry and Dr. Zaafran alluded to some of these things, but incorporating genetic testing. There's going to be probably using AI to determine a model of care that's personalized for that patient. Why do I respond to oxycodone, but my patient does not? I mean, those are things that we need to identify biomarkers and therapeutic targets for each individual. I think we're going to have improved imaging in the future, looking at the pathways for pain to see how what types of pathways, what type of brain activity they have, and why they may perceive the pain they do. Looking at other types of treatment, virtual reality. We're looking at how we can use virtual reality to basically distract that patient while we're doing a small procedure or a minor procedure. So I think there's going to be other alternative medical treatments, like acupuncture was mentioned, maybe some nutraceuticals, further non-narcotic methods. But I think we'll see a more expansion of those non-opioid, non-medical, medication-based therapies in the future.
Yeah, going with that too, so, technology was really kind of the next series of questions or future that I was going to get into. You mentioned a couple that I think are important to reiterate and ensure that the audience here knows that down the pike, I mean, AI, genetic testing, our worlds are colliding with artificial or virtual reality and things like that. What about the ones that exist today? What about the impact of things like telemedicine? Or how can we do more of increase access via remote access versus in-person therapy? Do you see some future hope in that area?
Well, it kind of goes back to the barriers, right? We talked about the barriers earlier on from the payment side of things. Also connectivity. If you don't have access to internet out in a rural area and you can't access telemedicine properly, that's another barrier. So payment, access, making rules, and again, this kind of goes back to the state medical boards to help, empower physicians to collaborate with others to actually do the right thing. I mean, that was kind of like the whole point of that gold plan that we were talking about. Incentivizing the use of telehealth, incentivizing the collaboration with those different disciplines out there to actually manage a patient in a proper manner. And the other thing, when Sarv actually talked about AI, predictive analytics. How can we better risk stratify patients who are going into a procedure as to who may actually be more at risk than somebody else, and helping make sure that we target those patients and properly address how we can maybe differently manage their pain post-operatively and so forth. But again, the chronic pain patients that are out there and making sure that they have that access that they need, which again goes back to payment and so forth. Again, it all really kind of goes back to how we as regulators and as physicians and clinicians can help take down those barriers to make sure that these patients have the access to the kind of care that they need, and that our regulators and legislators are not hindering the process, but maybe actually even promoting the process in a way that would be helpful to them.
And, Sherif, you bring up some great points. I think the other part of this is we need to kind of look at prevention in the future. How can we use genetic testing to predict who would be who has an addiction personality or underlying addiction disorder, so then we can manage their treatment before they go into surgery or they have any other procedures going forward. Now, that's before the patient gets addicted. But I think we have to use these genetic testing models in the future, just like we know that why some individuals don't respond to heparin and others do. We can use that information with the pharmacologic therapies that we use for pain control.
Yeah, so I think that all of these things are really somewhat exciting, I think, in the future of what we can provide going forward when it comes to pain management. As we near the end of our time together, I want to just acknowledge the fact that I recognize there are a number of people who they themselves are finding themselves in positions with acute and/or chronic pain conditions. And I'm glad that you were able to join to see the evolution of the regulatory environment, particularly as we move away from a very binary perspective on what is opioid use and non-use, and only a limited set of ways to approach that. I think the future is incrementally going to get better, certainly with access and addressing inequities, and certainly some of the regulatory changes that are coming. And I hope that you walk away with a little sense of hope from this conversation today, that our Federation of State Medical Boards is working very, very hard to help make this happen. As the AMA urges all state medical boards and state legislators to review their existing rules and use the updated 2024 FSMB guidelines. And doing so, it's our hope and our goal to help remove the stigma and harm that outdated, inappropriate rules and laws have caused. But once again, Hank, Sherif, Sarv, well-esteemed doctors and real advocates in the world of pain management, I want to thank you for joining us. Thanks, everybody.
Thanks, Michael.
This has been Moving Medicine, a podcast by the American Medical Association. Subscribe today to never miss an episode. Thanks for listening.